Okay, we are live, madam.
Yeah, hi. Hi, everybody. So today we are starting this exclusive classes on endometriosis because we were getting a lot of queries and both from the doctors and also from our patients regarding so many intricate things and also so much which is unanswered about endometriosis on social media, and many things are wrongly projected, and there are so many myths which are surrounding that. So we thought we will do these exclusive classes on endometriosis so that it creates awareness both among gynecologists and also amongst the patients who are suffering from the same for many years. So gynecologists, again, many a times who are working in setups where there is not much exposure to these kind of cases will find this classes very useful, since we are doing it in detail right from the basics. So today's class is about molecular biology. So as you all know, so this is an enigmatic disease where we don't know the pathology or the implications of what happens at the molecular level. So today's class will throw some light, if possible, on these things so that it becomes easier for us to understand the basic pathophysiology of the disease called endometriosis. Yes, please.
Yeah. So, hi everyone. And as Shilpa madam said, it was actually her idea to go into the absolute depth of this subject. And, this is one of my most favorite topics. So, I just want to tell that every class which we do, my team has sort of streamlined around 55 to 60 topics which can be discussed as masterclasses on endometriosis, and this is the first class, obviously. So this class is going to be focused completely on molecular biology, and what I am going to try and do is molecular biology is as such pretty boring, so if in case somebody has never read molecular biology for endometriosis, they are not going to like that subject at all. you know uh, it's God is pretty kind that we are doing a good amount of R&D with our own, hopefully our own lab in the next 6 months for endometriosis. So I've gone into a good amount of detail, and when you try and understand molecular biology, you will understand all the mechanisms of the disease. Okay, so I will start with the screen sharing, and I will try and correlate everything clinically as far as molecular biology is concerned. Okay, just let me know if my screen is visible. Yeah.
Yeah, it is.
Okay. Okay. So, when we try and talk of molecular biology in endometriosis, first thing first, endometriosis as such is a disease. Let's assume I'm drawing the bladder, I'm drawing the vagina, and I'm drawing a retroverted uterus. Okay. And a retroverted uterus with some adenomyosis. And here is the bowel. So, when I try to draw endometriosis inside this, let's assume I'm drawing a deep endometriotic nodule here and a chocolate cyst here. All right. So when I try to draw this, just try and understand the concept of something called as molecular signature. Okay. So the molecular signature for endometriosis and adenomyosis is completely different as against what do you see in a normal endometrium. So I'm just drawing the endometrium here and the endometriosis in one side. Okay, so if I draw the endometrium, just first thing, endometriosis we have all studied, it is a disease where there is something called as estrogen excess, right? There is excessive estrogen which is generated, and it is that estrogen which is going to give rise to all these particular problems. Okay, that is well understood, everybody knows that. And obviously when we talk of estrogen, I also want to talk of progesterone. Never miss out on progesterone because both these hormones now normally go hand in hand. Okay, in a normal lady, what is going to happen is when I look at a normal endometrium, there is going to be estrogen alpha receptors and estrogen beta receptors. This is something which we all know. And estrogen alpha receptors are way higher as compared to estrogen beta receptors when the endometrium is normal. But what is endometriosis? It is an abnormal endometrial tissue. Okay, it is an abnormal endometrial tissue. And the first thing we should understand is that the estrogen beta receptors are way more expressed as compared to estrogen alpha receptors whenever you have endometriosis. Now, the problem with these beta receptors is that these beta receptors also have an unusually high activity of this guy. Okay, and that is the aromatase enzyme. And because they have a very high activity of aromatase enzyme, they are able to convert very quickly androgen into active estrogen. Here comes the role of giving something called as letrozole, which we have propagated so many times. And I think Dr. Shilpa and Dr. Aarti will both agree that when we give letrozole plus registerone as a combination for patients who are on temporary management, for patients who are on waiting period for surgery, for patient who has adenomyosis, it definitely allows the patient to be in amenorrhea, and simultaneously it also allows the patient to be in some amount of pain relief. Okay, and this is the where this letrozole goes and acts on this aromatase enzyme which is present inside this nodule, and it suppresses the estrogen beta receptors. Okay, moving on very quickly onto progesterone. I will not be boring so much of theory. Progesterone again has two receptors, progesterone A and progesterone B. Now the blanket thing is this. All progesterone receptors are downregulated in endometriosis because it is a disease of estrogen dominance and progesterone resistance. There is no question about this. So now the obvious question is going to come, what rubbish, you are lying. If it is a disease of progesterone resistance, how does Dynogest go and act? How does Mirena go and act over endometriosis? Correct? Now remember, guys, Dynogest and Mirena are going to go and act onto normal tissue and prevent formation of new endometriosis. Okay, they have got no role in suppressing an already existent endometriosis. Yes, they can cause some volume reduction, especially Dynogest, because Dynogest also has some anti-angiogenic properties. I will come to that when we discuss our Dynogest masterclass in great detail. Mirena does not reduce disease formation. In fact, as soon as you stop Dynogest and Mirena, the disease will come back to how it was. In fact, if you keep Dynogest and Mirena continued, the nodule will stay as it is, because as such, endometriosis is a disease of progesterone resistance. And as a result of this, when you give letrozole, you always want to give letrozole plus registerone and never registerone alone, because registerone alone is not going to go and act in endometriosis at all. Now you can change your concept and say, no, boss, but you know what? I want somebody to go and act on both estrogen and progesterone. And that is where comes the role of giving GnRH agonist. And the GnRH agonist, which we normally would give, is going to be a Zoladex depot or a Lupride depot. And also, of course, the newer molecules like oral antagonist, which have come inside the market. These antagonists are typically available as a tablet of elagolix, and in a dose of around 200 milligram. It is going to cause suppression of both estrogen as well as progesterone, and it is going to cause a temporary reduction in the size of the lesion and a temporary reduction in the pain. However, both these drugs have their extreme limitations because they cannot be used for long-term usage. Both have limitations of not to be used for more than 6 to 7 months because they can cause severe loss of bone mineral density. After having understood this much, okay, and understood how these drugs are going to act, just remember one final thing. Okay, I will just delete the uterus from the diagram. Basically, this is all that you need to understand as a clinician about the molecular biology. These are your practical applications of the disease. Just remember one more thing. Both estrogen beta receptors and absence of progesterone alpha and progesterone beta receptors are going to upregulate something called as PGE2. This is nothing else but this is a prostaglandin, and there is a local upregulation of prostaglandin across all endometriotic lesions. And because there is a local uptake of this, now you will understand it very beautifully. Okay, this is an extremely polymorphic expression. That means in some people who have very small disease, okay, PGE2 can be upregulated disproportionately. And in some people who have extensive disease, okay, the PGE2 upregulation may not be so high. And this explains your concept that there are certain patients who are having very minor disease, especially peritoneal endometriosis, and they will come to you with severe pain. And there are some people who are having grade 4 endometriosis, and with grade 4 endometriosis, they will have no pain. Okay. This is because of the polymorphic nature of the PGE2. After having understood this, you have to understand one more concept in molecular biology, and that is a very simple concept. Because PGE2 is chronically upregulated, even if the patient is an asymptomatic patient for endometriosis, make sure that this patient is at least investigated and treated if need arises. All right. Because just because the patient is asymptomatic, it is a clear indication that there can be some amount of dysregulation in the PGE2 at the molecular level. It does not mean that the patient has no disease. It just means that the patient has no pain due to the disease. And because PGE2 is upregulated standardly, a lot of women take NSAIDs in the form of meftalspas, which we commonly see, which we commonly give for endometriosis, and it commonly works for endometriosis. All right. I was told to keep these classes as every topic is around 7 to 8 minutes. So I'm finishing the molecular signatures here. I have divided further classes into immunological aspects, how immunology changes, how there is immunomodulation in endometriosis. I am also going to be taking a class on dysbiosis, how the gut pelvic axis works, and I think that's a very interesting class. And after I do those 5 classes, understanding when to give medical management and when not to give medical management is going to be pure science. It is not going to be like how it is currently in India. You see endometriosis, you understand shit about it, and you just give Dynogest to everybody. And that is not how it works. If you understand the molecular biology, you will know why you are giving what. And when you know why you are giving what, now retrospectively, when you go home and think, you will understand that, okay, what we gave was probably making a lot of sense at that point in time. All right. So I'll be happy to answer 2 or 3 questions from Aarti madam and Shilpa madam before we conclude.
So, Jay, you beautifully outlined how molecular signatures, understanding molecular signatures is important in understanding therapeutic targets for management of endometriosis. I have one question about molecular biomarkers for diagnosis of endometriosis.
Yeah, so people have tried to studying molecular biomarkers for endometriosis, and now there is a combination of multiple parameters, 10 tests and 10 parameters which you can correlate together. It is not yet launched in India. Okay, it is just been launched in Australia, not that effective, but it tells you that the endometriosis is severe. And if that marker is positive, or if that bunch of markers are positive, then the patient straight has to undergo a surgery. Basically, it is a marker to tell people don't give medical management, right? And by the time it comes into India, I think it will be 2027, because it will have to undergo all the pre-regulatory approvals. And at this moment, it is pretty expensive to do.
So you spoke about choosing surgical over medical once you get this kind of biomarker test availability in India. So at the same time, do we have something where we can choose which drug will be effective in which case? See, many a times we do this
Yeah.
trial and error.
So that's a very good question. But see, again, ma'am, this molecular signature, when we try to talk of, whenever we want to study the molecular signature, the most important thing is we need to take a biopsy, and the biopsy has to go to the pathologist as a fresh specimen. And this fresh specimen then has to be processed under flow cytometry to give you an answer as to is there estrogen beta predominance and how much reduction of progesterone has occurred in all these types of things. At this point, it is very, very difficult to do it on a commercial basis, because these are very expensive tests to conduct, and you require that type of a research grant for somebody to do a molecular signature. So the first thing, in fact, the first R&D which we have undertaken is to do a molecular signature for just 50 people, which are going to be our own patients, where we are going to send them a specimen from the peritoneum, and per patient cost of doing the molecular signaturing is going to be approximately 19,000. Okay. That is additional to the cost of machines. So it's very, very expensive at this point in time.
Yeah. So in this class, what is it practically that you would want to tell people who are actually listening to this class? I mean, what is the point of having prostaglandin, all this, like, progesterone, estrogen. Nobody understands nothing about all such things. So
Correct.
finally, the clinician wants to know, okay, is it helpful in our diagnosis? Is it helpful in our management? Is it going to help us in counseling that patient further, whether there will be a recurrence, or what about the fertility index for that patient with endometriosis? So what is
Surely.
your take home point
Definitely.
with this
Yeah, yeah.
class?
Definitely. See, because it is a disease dependent on estrogen and progesterone, that is the reason why once your surgical excision is complete, you can give the patient oral contraceptive pills in order to prevent the growth of new disease at any other location. That is point number one, because you need something to take care of microscopic disease till the patient actually plans for conception. That is one. Let's assume the patient is awaiting surgery, and the patient, let's say, wants the surgery after 2 months, or let's say after 3 months. Then a much wiser option to give to the patient to reduce vascularity as well as the disease would be an option of letrozole plus regestrone, rather than giving a patient an option of Dynogest alone. All right. And remember one more thing: no matter how much we try to use GnRH antagonist or GnRH agonist, both of them are going to go at the central level and reduce estrogen, okay, or reduce progesterone at the receptor level. That is going to be purely temporary, because the flare up which is going to occur as soon as the effect of the oral medication or the depot goes off is going to be pretty severe to the patient. So when we probably try to look at the molecular biology, the first thing which we understand is that it is good when we excise the disease of at least what we see, and we don't want to have a new growth of the disease. It is not the gold standard when the disease is already present and you are trying to do something about it. Once the disease is present, none of the molecular signatures have even proven that it is going to cure the disease. That is proven in molecular biology, and that should be the take-home point, that for an existent disease, someday or the other, the patient will require surgery or the patient will require maintenance.
Yeah, so this is fine what you spoke. What about those perimenopausal ladies who come with endometriosis? If you are thinking that it is estrogen progesterone dependent, so if you do this biomarker, whatever these molecules, and do you think that we can just sit and wait for them to reach menopause to know whether it is really going to regress or it is not going to regress? I mean, what is your take on that?
Yeah, so that is actually a part of the next class, because then
Okay.
this is just one theory. There are so many theories as far as endometriosis, including stem cell theory, including immune shift theory, correct? And all these theories may play a role in every patient, or one by one in some or the other patient, right? And as a result of this, we need to be pretty certain that even if we try to counsel somebody that you're going to hit menopause, congratulations, your endometriosis will go away, it's not correct, because we are going to be taking a class on molecular establishment of deep endometriosis, where we are going to be proving molecularly that it is independent of hormones and it is independent of immunology, right? So no menopause is going to work in that situation.
So, Jay, by understanding the molecular signature of endometriosis, we know how to manipulate hormonally the milieu to temporarily tide past some symptoms, or post-operatively reduce the microscopic load of the disease. That is what you're trying to get across.
Correct.
And like
That's correct.
Shilpa asked about perimenopausal women, what would you do? Would you just wait? How would you manage a adolescent, severe endometriosis patient post-surgery? You can't, continue this hormonal manipulation forever. Even your registrone and,
Is 3 months.
physiologist for 3 months. Then after that, what?
So, madam, the best option in that situation, as we discussed already, is to give oral contraceptive pills who have a proven safety, right? Or oral contraceptive pills can safely be given to the patient at least for 9 to 11 months, and then they can have a 2-month break, right? So what we normally do is, for these adolescent girls, see, most of these adolescent girls are going to end up with a surgery, no matter what, because you will notice that in adolescence, the disease is often large. You will very rarely see a 1 centimeter cyst in an adolescent girl. In the adolescent girls, you are going to see 15 centimeter cyst directly, right? And it is going to be extensive disease, correct? This extensive disease, once you remove, there is a good theory which states that in adolescent endometriosis, it is actually the peritoneal factors which play way more important role than the hormonal factors, correct? But still, in order to reduce or in order to make sure that the disease doesn't come back, you can try giving patient oral contraceptive pills, okay, for a prolonged period of time with some breaks in between. So it gives them a washout window as well as allows them to maintain, suppression of the disease.
Okay. So thank you very much. We'll meet again with our next session. So thank you, everyone.